sleep aid side is a prescription medicine called Ramelteon. The trade name is Rosarum. It works through the melatonergic system. So just so you keep in the back of your name, Ramelteon or Rosarum. So apnea. During the daytime, during waking hours, you and I have some voluntary control of our breathing. We can take a deep breath in and hold it. We can breathe very quickly or shallowly if we want to. But at night, you and I don't have any voluntary control of our breathing, or when we're asleep, we don't have voluntary control of our breathing. So our breathing control center is where?
Brainstem.
What's the particular area of the brainstem? The reticular activating system. Okay. So the reticular activating system is constantly monitoring oxygen, but more importantly, metabolism of carbon dioxide through chemoreceptors. So your two largest collection of chemoreceptors in your body is in the arch of the aorta and then your reticular activating system. So when you're on Jeopardy and Alex Trebek asks you the chemical which stimulates you to breathe at night, don't say oxygen. It's the metabolism of carbon dioxide. So chemoreceptors are looking at carbon dioxide tension in the blood all of the time. And those chemoreceptors, especially in the arch of the aorta, are sending information to the reticular activating system to tell your respiratory system to breathe, 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 breathe. Now, there are a number of medications and or conditions that can affect the way that we breathe. So respiratory suppressants such as alcohol, benzodiazepines, and opiates can make our reticular activating system sluggish. That's how people overdose and die, right? So we have respiratory suppression, then cardiac abnormality, and then we just don't wake up. Also, there are other things that will affect the reticular activating system. If someone has had surgery in the arch of the aorta, the chemoreceptors are not functioning potentially correctly there. These patients are at greater risk of a particular type of apnea that we'll talk about in a minute. Also, patients who have had a brainstem stroke are at increased risk of apnea or alterations with the reticular activating system. So when we're sleeping, our brain marches through different stages. And someone super smart named these stage 1, 2, 3, and 4. And the last stage is REM, or rapid eye movement sleep. Now, just because they're listed in numerical order does not mean your brain moves through them in numerical order. So stage 1 sleep is slow, eye-rolling, nodding off sleep during a boring lecture. Stage 2 sleep is as we've drifted on off during that lecture, but we are very easily aroused by a dog barking, a trash truck going by, something of that nature. Stage 3 and stage 4 sleep in the world of sleep medicine has really been grouped together now over the last 5 to 8 years into what's known as slow wave or delta wave sleep. And that's because if we look at the electroencephalogram tracing of delta sleep, it's a very classical slow wave delta electrical pattern. And so delta slow wave sleep is a pretty refreshing form of sleep. It's more difficult to get aroused out of that form of sleep. If we are aroused out of that form of sleep, it's fairly easy to get back into sleep. And then the final stage of sleep is REM sleep, rapid eye movement sleep. And this is where dreaming occurs. When we dream, we lose muscle tone, so we don't act dreams out and harm ourselves or our loved ones in bed at night. So we lose skeletal muscle tone, not smooth muscle tone. So if we were to lose smooth muscle tone, we'd have a lot of trouble, especially from an arterial and venous side, right? And a respiratory side, right? Now, just because we have skeletal muscle loss, what is cardiac tissue?
Muscle. It's cardiac muscle.
So we don't get relaxation of the cardiac muscle, obviously, during REM sleep. So since we don't have that skeletal muscle innervation during REM sleep, we're at greater risk or greater propensity of crowding in the upper airway because we're not pulling the large neck muscles up out of the airway. Okay? But there's also smooth muscle in the airway, the upper airway, correct? So you might say then, well, what if I'm a fairly thin postmenopausal woman? Why is my apnea risk increased? Because I'm not an overweight guy with a big neck. Because smooth muscle is innervated by estrogen. And if we lose our endogenous estrogen production, whether it be through surgical removal or natural menopause, postmenopausal patients are at greater risk of crowding in the upper airway because the smooth muscle is not innervated by that larger production of estrogen. So we know that skin turgor is got an interaction with estrogen, so that's why as we age, our skin is not as compliant, our airway is not as compliant, our smooth muscle vasculature is not as compliant, so estrogen plays a role in that airway as well. So if we get crowding in that upper airway, we can reduce the volume of air that flows into the lungs. And now if we have a reduced volume of air, we have less oxygen available to diffuse across the lung tissue. So apnea in and of itself has nothing to do with an abnormality in lung function. It's all about a volume issue. If I reduce the ability of the volume of air to flow through a crowded upper airway, I have less volume of air in the lungs, less oxygen available to diffuse across the lung tissue. If my brain recognizes a change in oxygen saturation, a number of processes are activated in an attempt to keep you safe. First thing that happens is your brain says, I need more transport mechanisms. And what are those? Red blood cells. Contain hemoglobin, grab onto oxygen to transport oxygen to the major organ systems. How do we produce red blood cells? Yes. So the kidneys are told to produce erythropoietin to stimulate bone marrow to increase red blood cell production. So in your untreated apnea patients, if you do just a simple CBC on them, you're going to actually see a lot of them have hematocrits that look like smokers. So they have an elevated hematocrit, so a larger amount of red blood cells circulating in their plasma volume because their brain has responded by saying, I need more transporters, and the only way to do that is to stimulate the kidneys to produce erythropoietin, to stimulate bone marrow, to produce red blood cells. Now what happens though in this very simple, I want you to dumb your cardiovascular system way down. It's a closed loop of garden hose with a pump on the end of it. Now, the good Lord designed that system such that if we have a normal volume, what is our normal volume about?
Normal volume of
Normal blood volume.
in your whole body.
Mm-hmm.
5 liters.
You guys know I'm not a student anymore, I don't have any idea.
5 liters.
So you've got a normal volume, whatever that might be. And it is designed such that that pump can course that fluid around the system. Now, our arterial side is not real compliant. We don't have a lot of expansion that can happen on that side. We do have some way by which to deal with fluid overload on the venous side because the veins are a little more forgiving, but the arterial side is not. So when we increase our red blood cell production, we have in a sense changed the hydraulic nature of the fluid coursing around that system, correct? And if our hematocrit rises too high, we get sludge, correct? So if the system does not have the proper hydraulic fluid to move around, what does the brain also need to do? We need to try to return to homeostasis, and that is, the brain also stimulates the kidneys to filter more fluid so that we can add some into our plasma volume to then try to move back towards homeostasis when it comes to hematocrit. Here's the problem. We have a closed system. When we add more volume to a closed system, what's the only way by which we can get it to go through that system? Increase the pressure. It's a pressure volume loop, right? So I have to increase my pressure. I have to increase my front load pressure to get it out, but I'm also increasing my back load pressure on the heart as well, because where are you going to put this stuff? I'm pushing against myself all of the time. This is the main way by which untreated apnea patients develop hypertension. Okay? What also happens, the heart tissue is like no other muscle in your body. If we work it out, it can get what? Enlarged. So we can get cardiomyopathy. Did you say tired? It can get enlarged. So, untreated apnea patients are at greater risk of hypertension because of this process, but they're also at greater risk of cardiomyopathy. But enlarged heart tissue doesn't function more efficiently, it functions less efficiently as a pump. So, untreated apnea patients are at greater risk of congestive heart failure. We know that congestive heart failure patients, they're at greater risk of changes in how the respiratory center recognizes their oxygen need. So, heart failure patients may have been caused by obstructive apnea, but heart failure itself can lead to central apnea. So what is central apnea? Central apnea is a brain-generated phenomenon to slow the respiratory drive. So you say, how in the world do we figure that out? And we'll talk through sleep testing in just a second, and I'll tell you how we're going to figure out central versus obstructive apnea. But heart failure patients can be caused by untreated obstructive apnea, but heart failure can lead to central apnea. So other things that can happen with reduction in oxygen level, the brain has to rob certain processes to keep the systems alive. The easiest place to rob is metabolism. So just like a fire in your fireplace, your metabolism needs oxygen to burn sugars, calories, carbohydrates. But we can go into hibernation mode. And your body will do that if you've got an untreated apnea. So what happens is metabolism slows down to a crawl. So when we sleep, we rest, digest, and divest, right? So we slow that metabolism down. So what happens with those sugars, calories, and carbohydrates? We got to pack them on somewhere, right? So we start increasing adipose tissue. Adipose tissue is where peripheral insulin resistance begins. We put more stress and strain on the pancreatic system, and we're down the road to type 2 diabetes. So there is a direct connection between untreated apnea, insulin resistance, and the development of type 2 diabetes. So now your untreated apnea patients are at greater risk of hypertension, type 2 diabetes, cardiomyopathy, and congestive heart failure. We know as insulin resistance begins and blood sugars fluctuate, triglycerides will rise, and ultimately we have an increase in inflammatory markers that will be present because the body is under stress. Atherosclerotic plaques are not just cholesterol, they are induced by inflammation, and it's the inflammatory response in the intima that allows the plaques to form. So if we have a constant inflammatory process that is going on, our untreated apnea patients in the medical literature, it's very clear that they are at greater risk of hyperlipidemia, putting them at greater risk of stroke, heart disease, and heart attack. So the reason we screen for and treat apnea is not so that we can just give them all dawn dish soap sleep. We do want to improve their quality and quantity of sleep, but I want to protect their heart and their brain. We also know that low oxygen levels will induce the brain to produce epinephrine. So Very classical, you're going to have a patient come in, the wife is going to make the husband come in, she's going to say he snores loudly, and then he stops breathing, and you get a classical snort, jerk, gasp. And that is him trying to restart his system. With that, we will have a release of epinephrine. Now, very commonly, these patients may say, I wake up multiple times through the night with difficulty getting to sleep. Our sleep maintenance insomnia patient. Why? If you've watched a scary movie and you've gotten scared and you've got this rush of adrenaline and you're breathing more quickly and you're feeling maybe a little sweaty, anxious, closed in, can you lay down and go to sleep? No. That's adrenaline, correct? That's exactly what happens with hypoxemia. So this is why it's very, very, very necessary when patients come to complain to you that they have multiple awakenings through the night with difficulty getting back to sleep, and they'll try to tell you, oh, it's because of my pain, or it's because I gotta pee. Screen them for apnea. Very commonly, the gentleman that comes in and says, I need to get up and pee 5 times a night because it's my prostate, screen him for apnea. Why? Because whenever I have crowding in my upper airway, and I'm trying to breathe in to overcome that, I'm putting a negative pressure down on my bladder, giving me the sensation of needing to urinate. I'll wake up because of that apneic event and have the sensation to need to urinate. So I think I woke up because I've got to pee. It's not that. It's the apnea that woke me up. It's the neurochemical release that's keeping me awake, and now I'm awake to say, oh, I need to pee. But all they think of is I need to pee, and that's what woke me up, and that's not it. Additionally, untreated apnea patients are at greater risk of gastroesophageal reflux. So commonly they might come in and say that I've got nocturnal reflux. And it's because that negative pressure is putting pressure up on the stomach, pushing that content through the lower esophageal sphincter, and we're now getting reflux. What happens when they do that snort, jerk, gasp? We now aspirate that irritant into our lungs. So untreated apnea patients very commonly will present with reactive airway symptoms. And it's not that they've got asthma, it's because they've got nocturnal aspiration from their reflux. Okay? So now our untreated apnea patients are at greater risk of stroke, heart disease, heart attack, hypertension, hyperlipidemia, type 2 diabetes, cardiomyopathy, congestive heart failure, sleep maintenance insomnia, nocturnal reflux, anxiety. So patients will present to you and say, I've got nocturnal panic. I wake up scared, I must have had a bad dream, I need some sleep aid, I need some Ativan, I need some Xanax. No, you don't. I don't need to suppress your respiratory drive even more than what's already going on right now. We need to treat your apnea. Okay? So our loved ones, our parents, our spouses, they're good at a lot of things. Insurance companies don't think they're good enough to tell us if we've got apnea or not. So if you think apnea is present, we can't just listen to the spouses or the loved ones. We actually have to go through testing. Now, just because someone snores, that's not indicative of apnea. Snoring is a vibratory nuisance of tissues in the upper airway. People can snore very loudly and not have apnea. Other people can not snore whatsoever and have profound apnea. We know that from people who have undergone uvulopalatopharyngoplasty, and we'll talk about that briefly as a treatment that I don't suggest for apnea on a routine basis. But snoring is not indicative of apnea. What snoring, though, can tell spouses or loved ones is changing in the quality or the quantity of that snoring can be indicative of my husband snores like a freight train, and then all of a sudden I hear him stop and I count, and then he starts breathing with that. You're having an apneic episode. So snoring in and of itself is not an abnormality, but changes in the quality or quantity of that can tell you a lot of information. Snoring, so you may think that when I snore, I'm vibrating the tissues in the upper airway. Very commonly, these patients will drop their mouth open at night and become mouth breathers. The good Lord designed us as nose breathers, not as mouth breathers. Saliva is a good lubricant for mastication, for chewing food, for swallowing. It is not a good humidifier. The nose is the body's natural humidifier to heat and humidify before it gets down to the lungs, as well as to filter out any large particulate matter. But when we vibrate these tissues together, they get engorged with blood. We increase our nasal airway resistance. We want to drop our mouth open at nighttime. Patients will often complain of the very fancy term of xerostomia or dry mouth. They may have some enamel erosion. Untreated apnea patients can have bad teeth over time because that dryness is drying out and destroying that enamel. Not uncommonly, apneic patients may complain of clenching and grinding, and that's to try to keep muscle tone in the upper airway. So you've got a whole host of things that these apnea patients may present with. I think we talked about all those things. So how do we evaluate this? Gold standard form of evaluation is polysomnography or sleep testing. Over the last few years, to save money, insurances have pushed a lot of folks into home-based sleep testing. I'm not a big fan of home testing because I just don't think it's not nearly as accurate as it is in laboratory testing. I will nearly demand in-laboratory testing every time I can get it because it's far more reliable. So polysomnography involves a patient going into the laboratory, usually between 8 and 9 o'clock at night. They're wired up a little bit like the Bride of Frankenstein. Don't lie to your patients, they really are. We need to know electroencephalogram tracing. I need to know about heart rate and rhythm. I need to know about muscle movements, oxygen content in the blood, and efforts to breathe. So one thing that we're doing through the night is we're looking at the electroencephalogram tracing. That way we know what stage of sleep they're in. We're looking at cardiac rhythm. Most common cardiac arrhythmia in untreated apnea patients is nocturnal bradycardia. Second most common is atrial fibrillation. Every atrial fib patient you see needs to have sleep testing. So we're monitoring for cardiac abnormalities. We're monitoring for muscle movements, so periodic limb movements. We're monitoring for oxygen saturation. We're monitoring for respiratory effort. So, yes?
Sorry, what was the first one you said?
Bradycardia.
The most common.
Bradycardia.
Bradycardia.
Yes. And then the second most is atrial fibrillation. So, how we decipher apnea versus obstructive apnea versus central. So during the nighttime, we're adding up the number of apnea events. And apnea is defined as a 70% reduction in airflow for at least 10 seconds. We also monitor for what are known as hypopneas, Hypopnea. A hypopnea is a 30% reduction in airflow for at least 10 seconds with an associated 4% drop in oxygen saturation. So both of those two things are considered clinically significant, and we add those up through the night, and we divide them into the number of hours slept to get an index. Insurances like classification levels. They want a first, second, a third, a gold, silver, bronze, a mild, moderate, or severe. So apnea is broken down into severity categories. Less than 5 breathing changes per hour is normal, between 5 and 15 an hour is mild, between 15 and 30 an hour is moderate, and greater than 30 an hour is severe. All apneic levels, mild, moderate, or severe, are all at the same level of developing any of the ugly things that I told you about earlier. So I treat all apneics, whether they be mild, moderate, or severe, the same way. I don't choose to not treat mild because it says they're mild. Mild is only because that's what the insurance classified it as. To me, apnea is normal or abnormal. Abnormal is all treated. So how do we figure out central versus obstructive? Patients wear a piezometric or a plasmography belt at night. It's basically a stretchy belt around their chest. This belt is going to tell me about respiratory effort or respiratory excursion. So if I have an apneic episode that's crowding in nature generated from the upper airway, we're going to see a patient have activity on the piezometric belt. They're going to be trying to breathe in to overcome that. So we know that's an obstructive apneic event. Now, if we see an apneic event and we look at the piezometric belt activity and there's no piezometric activity whatsoever, you know that's a central apneic event. Those are how then the data is scored through the nighttime to know, is it an obstructive event or is it an obstructive or a central event. Some patients may have primary central apnea. So this may be a congestive heart failure patient. This may be an opioid or benzodiazepine dependent patient that's taking these medicines at bedtime. They can have a primary central apnea. An alcoholic patient can have a primary central apnea. A brainstem stroke patient, an arch of the aorta surgery patient can have central apnea. Obstructive apnea, crowding in the airway. Can we have both? Absolutely. We can have mixed apnea patients. We can have people who have both central and obstructive apnea patients. Sleep onset central apnea is normal. You and I, when we go to sleep at night, you may, and you see this fairly profoundly in children, if any of you, who has children here? So if you've seen a child go to sleep, oftentimes you may see them and their breathing starts to get kind of erratic and it may stop and then I don't know if you've ever noticed that or not. This is witnessing sleep onset apnea, central apnea. All of us have the potential for a sleep onset central apneic episode when we first go to sleep, but then the reticular activating system takes over after we're no longer conscious per se and kicks in and does its job. So it's basically a state boundary. It's where you're moving out of being able to be in control somewhat of your respiratory system and your brain completely taking over, and it's during that state shift that we can get a treatment onset, a physiological onset central apnea, and that's normal. One of them or two of them at onset of sleep is normal. It's only when they persist beyond 5 an hour that it becomes abnormal. So the diagnostic portion of the study is us deciding if apnea is present and what is the severity of that apnea. If apnea is present, then we need to look at the treatment portion of that. Treatment portion of testing is what's known as positive airway pressure titration. So positive airway pressure is basically sealing the nasal airway to provide a pneumatic splint or an airway splint to keep the tissues pushed up out of the airway so they don't crowd down at nighttime. So when I first started in sleep medicine, the whole concept of this split night evaluation where you would spend the first half of the night doing a diagnostic portion and the second half of the night doing the treatment portion was really unheard of. The gold standard still to this day is single full night diagnostic testing, single full night titration. No insurance will pay for that anymore. It's really, really difficult to get it paid for. There is no code for a split night evaluation. So you don't have to remember this, but the diagnostic code is 95810, the treatment code is 95811. Insurances want you to get approval for a 95811 and to do a split night evaluation, which means they want you to try to get a diagnosis within the first 2 hours of sleep and then have at least 2 hours left in the night to wake them up, put them on positive airway pressure, and spend the rest of the night titrating that pressure. Why is it that we need to titrate pressure? Positive airway pressure devices will go from 4 to 25 centimeters of water pressure. Everybody's pressure need is different when we look at the airway and what's required to splint that airway up out of the way. We can get treatment-induced apnea. So if I provide someone an inappropriate amount of positive airway pressure at their device, I can actually confuse their reticular activating system and induce central sleep apnea. So we actually see a phenomenon known as treatment-induced central sleep apnea, which we have to deal with because some people's brains don't respond appropriately to positive airway pressure, and so I've got to have a pressure to keep their tissue splinted out of the airway, but this is a pressure enough to where it confuses the brain, so I'm now having to look at utilizing a different type of device that we'll briefly touch on because you don't need to learn all the devices just yet. So split night is basically trying to get everything done all in one night. If we do home testing, you can't do it that way. Home testing is basically you're trying to do a diagnostic test. Usually you'll do 2 to 3 nights that they'll keep the device at home. It's a small device that they'll wear with a nasal cannula. They may have a piezometric belt, a little wristwatch that's keeping the data, and a disposable oximeter. The data is not nearly as accurate, but we could still get a respiratory disturbance index. We can't truly count apneas because we don't often know how accurate the piezometric belt is to get obstructive versus central apneas. So instead we're getting what's known as a respiratory disturbance index, and this is just what we think are apneas, whether they're obstructive or central. The index is the same calculation, and that's how the diagnosis is made. If somebody undergoes home testing, commonly they'll be placed on an auto-adjusting positive airway pressure device where we'll give it a pressure range and we'll let the algorithm in the machine adjusts the pressure based on calculating the airway resistance in the airway to decide what pressure is needed, and then we narrow that pressure over time. It's a much more complicated way by which to treat. Other forms of testing. Multiple sleep latency testing. This is what we utilize to look at excessive sleepiness syndromes, patients who may have narcolepsy. So multiple sleep latency testing is basically somebody goes to the sleep laboratory during the daytime, and they usually have 5 scheduled 20-minute naps, and you're basically put in a dark, boring bedroom and told to go to sleep. And what we're looking at is sleep latency, how quickly somebody goes to sleep, and rapid eye movement sleep onset. So we want to see how quickly does somebody go to sleep, and do they get into rapid eye movement sleep during this 20-minute nap. It is abnormal for the brain to get into its first segment of REM sleep prior to about an hour to an hour and a half. So in narcolepsy patients, it's pathognomonic that they will have a very shortened sleep latency, but they have to have at least 2 sleep onset rapid eye movement events out of those 5 naps. And so multiple sleep latency testing, just remember in your brain, that's what's used to look at narcolepsy. I'll tell you on the PANCE exam and the PAN-RE exam, I wrote most every question there is when it comes to sleep. So I'll just tell you that you don't have to get in as much detail as what I'm telling you. Just know that multiple sleep latency is how we look at excessive sleepiness. Now, when you're evaluating an excessive sleepiness patient, you've got a bell curve. We don't have time to really talk a lot about narcolepsy, although it's an hour lecture in and of itself, but you've got 2 greater areas of risk for seeing that. It's basically your late teens, early 20s, and your middle 40s, and female patients are at greater risk than male patients. People who have had significant viral illnesses are at greater risk of developing excessive sleepiness syndromes. So when you're evaluating somebody that may potentially have a narcolepsy, you need to ask them if they've ever had Epstein-Barr virus or viral meningitis. It's very common that those 2 go hand in hand with the development of an excessive sleepiness syndrome. There's some really good research that shows that prior exposure to Epstein-Barr virus will cause orexin depletion. So we think that the virus itself attacks the neuropeptide orexin. The problem is that we don't have pre and post data. It wouldn't be really ethical to measure somebody's orexin levels, give them Epstein-Barr, and then see what happens later. All we can do is say, if we look at normal controls versus those that have had Epstein-Barr, there's a correlation there, and we kind of extrapolate that risk there. Maintenance of wakefulness testing, this is sort of the opposite of multiple sleep latency testing. This is you get put in a dark, boring room, and you're told not to go to sleep. But you can't use excessive means by which to keep yourself awake. This is used mainly for truck drivers and pilots that have obstructive apnea or that have treated excessive sleepiness syndromes, that we have to prove to the Department of Transportation or to the aviation folks that these people are appropriately treated and that they can stay awake during very nominal stimulus times and be able to perform their function of their job. You don't see a lot of maintenance of wakefulness testing performed nowadays, but DOT is requiring more of that. So positive airway pressure, there's multiple different types. So the traditional CPAP is continuous positive airway pressure. This is all one pressure all the time, whether you're breathing in, whether you're breathing out. Bilevel positive airway pressure is when you breathe in, you're at one pressure. When you breathe out, the machine drops the pressure by 4 centimeters of water pressure. I am not a fan of bilevel positive airway pressure. This was really developed for those that may complain of a difficulty breathing out against a CPAP pressure. Now here's the problem. If I have a patient who requires 16 centimeters of water pressure to splint their airway, and they complain at me that the pressure is too hard to breathe out against, and we say, okay, we'll put you on a bilevel device, so when you breathe in, it's at 16 centimeters of water pressure to splint your airway, but when you breathe out, for your convenience, it's going to drop you to 12 centimeters of water pressure. What do you think is happening to their airway at 12 centimeters of water pressure? It's collapsing. So if they were going to be treated at 12 centimeters of water pressure where they could breathe out more easily, I would have put them at 12 centimeters of water pressure. So to me, bilevel pressure just puts them at risk of apneic events every time they breathe out. Because some of the machines are not designed with an automatic, let's just call it injection pressure. Some machines will time, and they'll say, if you're not triggering the breathe in, I'm going to force it down your throat either way. Some of the machines are, we're just going to wait for you to breathe, and then it'll trigger and ramp the pressure back up. So really, if bilevel positive airway pressure needs to be used correctly in somebody that needs 16 centimeters of water pressure, they need to be at 20/16. That way when they breathe out, I'm keeping their airway splinted open. Well, if they're complaining at me at 16 is too high, if I'm going to use bilevel correctly, it's not going to work. So I don't use bilevel positive airway pressure very often. Adaptive sternal ventilation. This is the primary treatment for central apnea patients. So adaptive servo ventilation actually uses ventilator technology in a box to memorize the breathing patterns of a patient and look at when it is that they need to be breathing, and will actually inject pressure and tell them this is when you got to breathe. Plus, it uses an end expiratory pressure. So when you get into your clinical rotations and you do your pulmonary rotation and you see patients who are on ventilators, you're going to see somebody that's on PEEP, positive end expiratory pressure. So adaptive servo ventilation actually uses a method similar to PEEP whenever they breathe out, and that's to keep the airway splinted open, and then it will stimulate them to breathe by then ramping that pressure back up. Adaptive servo ventilation is the primary treatment for central apnea. However, there was a bit of medical evidence that came out about 3 years ago that showed an increased mortality rate in congestive heart failure patients on adaptive servo ventilation. And I already told you that congestive heart failure patients are most likely central apneics. We can treat central apneics with adaptive servo ventilation as long as we know that their central apnea was not caused by their congestive heart failure, if that makes any sense whatsoever. So let's say that they've been sleep tested off opiates and don't have central apnea, but they've got congestive heart failure, and they're tested on opiates and they have central apnea, and they need the opiates for the treatment of their pain, and we're going to treat their central apnea. We can treat them with adaptive servo ventilation and be following the gold standard practice of medicine, because we're not saying that their apnea is directly related to their congestive heart failure. So treating congestive heart failure patients with adaptive servo ventilation allows a lot, it makes us jump through a lot other hoops, and we have to have all kinds of sign-offs on the patient's aware that we could kill them with ASV, because, but don't worry about that, only us sleep folks will do that. Auto-titrating is where we give the machine a pressure range, and we let it use its brain, and it has a mathematical algorithm in there to adjust the pressure setting for the needs that the patient might have for splinting their airway open. We oftentimes will use auto-adjusting devices in the beginning of treatment as we're trying to let that patient kind of settle into where we need, and then we'll narrow that pressure range down. And then non-invasive ventilation is something that's really used for patients that have obesity hypoventilation syndrome or have some other acute respiratory distress syndrome or chronic respiratory failure, that non-invasive vent is used in a home setting. Treatment. So gold standard form of treatment for obstructive apnea is positive airway pressure. To be complete, we'll talk through the other options. So one option is to do nothing, and the patient accepts all risks and negative outcomes of untreated apnea. You just got to document if they refuse treatment, if you know it's there, because they're at greater risk of all those big and ugly things. Positional therapy, elevating the head of the bed. Is it going to cure things? No, but is it going to help somewhat? Yes. So positional therapy can be of some benefit, but it's not going to be curative. Mandibular advancement device. This is a special device made by a dentist. It's worn in the mouth at night to advance the lower jaw and keep the tongue pulled forward out of the airway. The problem is, Medical insurance won't pay dentists to do work, and dental insurance won't pay for medical devices, so they started about $2,000 out of pocket. Medical literature will show you less than 0.5% of mild apneic patients can potentially benefit from a mandibular advancement device. Moderate and severe apnea, there's no way. You'll have to pull the jaw forward too far. You create a temporomandibular joint problem, another thing that medical insurance does not want to touch. So I will tell you, in the 10 years I've been practicing sleep medicine, I have never seen a mandibular advancement device work. They become expensive paperweights. Uvulopalatal pharyngeoplasty, ear, nose, and throat surgical procedure, where you remove the tonsils, the adenoids, the uvula, and part of the soft palate to try to debulk the airway. In my experience, this just makes apneics quiet, and they come back and see you after they've had their stroke or their heart attack, wondering why. And we told them, if you had a UPPP, you need to come back and be retested so we know what your apnea is like. They basically just made you quiet. They removed all those tissues that can vibrate in there, and now you're a quiet apneic. Tonsillectomy, adenoidectomy is the treatment of choice in children. So what I didn't tell you, when I told you mild, moderate, severe in adult patients is less than 5 is normal, 5 to 15, 15 to 30, greater than 30. Children are a all or none. So children,
Bless you.
it's only one breathing event per hour, and children can be diagnosed as an apneic. So it's abnormal for children to have more than one apneic episode per hour. And the primary treatment for apnea in children is tonsillectomy, adenoidectomy, and then retest. And I will tell you, my daughter had profound apnea as a child. We had the tonsils and adenoids removed, retested, we're all good. So let me ask you this. How many of you think that the largest probability of apnea is an overweight male?
Okay.
I think it's a trick.
It is a trick. The highest probability for apnea worldwide is the Asian population. And it has to do with craniofacial differences in the way the airway is designed. The other thing you have to think of is genetic, the genetic propensity for. So anytime you see a trisomy, a Downs patient, you need to be thinking apnea just because of the way that their airway and their craniofacial. But it is the large overweight male does have, he ranks up there pretty high, but apnea knows no gender, no age, no race, no ethnic background. But just don't be fooled that a thin female that complains of insomnia can have just as big a propensity for apnea as the large overweight guy that snores real bad. Movement disorders, restless limb. So restless leg is a misnomer. It's not just the legs, it can be any of the limbs. Contrary to popular belief, restless limb syndrome was not first found because we finally had a drug to treat it and got put on TV for people to go ask their medical providers about. Restless limb was actually first described in early Greek times, believe it or not. So this particular syndrome has been around for a long time. Very commonly, patients will tell you that they get this creepy, crawly, irritated sensation in their legs or their arms when they're trying to get comfortable to lay down in bed. It helps them if they stretch or they get up and they walk around. About 30% of restless limb patients will complain that it causes pain. Please do not jump to just put them on Requip or Mirapex. Most common cause of restless limb in a patient is anemia, iron deficiency anemia. Anybody that comes in complaining of restless limb that you think that you need to work them up for that, you need to run a CBC and a ferritin level. So you need to look at iron storage levels. Patients who have restless limb that have an iron deficiency anemia, commonly their CBC will look normal, but you'll look at their ferritin level and it will be absolutely depleted because they're using every bit of their iron storage to try to keep their blood count looking normal. So ferritin level is what's indicative of looking at treating that restless limb patient. Well over 85% of those restless limb patients that have that anemia component, if you will treat them with 325 milligrams of iron plus vitamin C twice a day, within a month they will tell you it's completely gone. Now iron will constipate them, and I prefer ferrous gluconate over ferrous sulfate because it's easier on the gut and they can tolerate that better. So iron deficiency is the main thing you want to think of with restless limb. The other thing is that there are certain medications that will induce restless limb. Older antihistamines will induce restless limb. Certain cardiovascular medicines will induce restless limb. Certain psychiatric medications will induce restless limb. So you really want to look at their medication list, ask them what they're taking over the counter as well to look at restless limb. Now, if it is that you've worked everything up and that their sleep testing is normal, their blood count and ferritin level is normal, they're not on any drugs that may induce restless limb, then you could potentially look at treatment of that, and these are dopaminergic drugs. They're anti-Parkinsonian drugs, which were found to be beneficial in reducing restless limb. Why? Because Parkinsonian is a movement disorder, and restless limb is a muscular movement disorder. So Requep and Mirapex are utilized for the treatment of restless limb. I will caution you if you prescribe those. Not only are they sedating, but you need to give patients the warning about pathological impulsive behaviors. So what did we talk about the neurobiology of addiction to dopamine? We increase dopamine and it's going to increase the whole pleasure cascade, right? It is well known that the anti-Parkinsonian drugs, one of the side effects is pathological behaviors such as pathological gambling, pathological sexual behavior, spending money without regard to their financial situation, almost some symptoms that could be indicative of patients who have bipolar disorder in a manic type phase. There is a provider actually in Oklahoma City that was successfully sued for malpractice because they had prescribed Mirapex for restless limb out of a sleep clinic and did not give the patient the warning. They basically spent all of their life savings, their husband's 401k, everything they had, hawked the house, the car, and everything just to buy clothing over and over and over, and that provider was successfully sued in court for malpractice for not giving that warning. So Requip and Mirapex can reduce restless limbs, but you need to look for everything else first. If you choose to utilize those medicines, you typically would dose them at nighttime or in the evening. If it is that patients come back to you and say, that worked, but now I'm starting to get the symptoms earlier, and I need to dose it earlier in the day, and so now I need to take it twice a day. And then they come back and tell you, oh, it's happening even earlier in the day. It used to be right before bed, and now it's happening around 2 o'clock in the afternoon. This is a phenomenon known as augmentation. Augmentation is actually an adverse effect of the dopaminergic drug in the muscle motor system. The primary treatment, the only way you can get augmentation to leave is to stop the drug and not go back to it. It's an adverse effect to the drug itself. Now you can retry later down the road, but you need to wait several months because they'll just begin to augment again. Don't go up in dose. Don't keep adding doses earlier in the day. If you have someone that needs you to add doses earlier in the day that were well controlled before, they're augmenting, they'll argue with you till the cows come home that they need it earlier in the day, you've got to stop the drug.
What about magnesium?
So magnesium has a number of wonderful uses. Magnesium is a natural stimulant for the bowel. Magnesium will also help reduce muscular cramping and pain. The thing with magnesium that we have to be careful of is cardiovascular interaction. So if we've got people that are supplementing with a lot of magnesium because they're trying to treat their restless limb because they've got an anemia and they really need to be treating with iron, we can have some hypermagnesemia, and that can cause bad stuff. So we just have to be careful there. Off-label stuff for restless limb, some people say that about 30% can manifest as pain or cramping. So Old school, it used to be that we could use quinine. You can't get quinine over the counter anymore now. They basically took it off and said it's only approved for the treatment of malaria, but we know that quinine can help reduce muscular cramping. You can still get quinine over the counter, you just have to get it through tonic water. And for a science experiment, if you take tonic water and you put a black light up to it, it'll glow green. Why is that? So quinine comes from the bark of a tree in South America. That's how it was discovered with the folks that were going to South America. They wanted to prevent malaria, so they were getting the bark off of the tree and it tasted nasty, so that's how gin and tonic came about. They were mixing it with their spirits to keep the bitterness away. But quinine has a photoluminescent property to it, and it's just the way that the light refracts off of that chemical dissolved in water and it will glow. It's a pretty cool science experiment for a kid. Periodic limb movement disorder, this is completely separate than restless limb. Periodic limb movement is where we'll see at nighttime folks in bed that are asleep. Restless limb patients can describe it to you. They know it's there. Periodic limb movement disorder is where the spouse comes in and says they kick all night long. And the other spouse says, I got no idea. Or you change your sheets and you notice at the bottom of the sheet you're constantly tearing up the bottom of the sheets. They're always worn. This is a periodic limb movement disorder. Most commonly this is untreated apnea. This is the body trying to keep muscle tone so that we don't have apneic episodes. Now there can be people that have periodic limb movements that don't have apnea, but it's not real common. The dopaminergic drugs like Requip and Mirapex failed in trial to treat periodic limb movement disorder. So they don't really work well with folks that are not aware of their movements in bed at nighttime. Just for kicks and grins, one of the tertiary treatments for restless limb, if you get down the list, is opioids and benzodiazepines, but I prefer not to use those. But in severe cases, they have been used. Okay, probably, what time is it? You all need a quick pee break before we do circadian rhythms and then we'll be done? Okay. Let's try to do quick pee break, then I can get you out a few minutes early, unless you all just want to keep going.